Thank you, Kelly, and thank you everyone for having me. My understanding of today's presentation was that we were going to do a question-answer panel session, so I don't have a formal presentation set for everyone, but I do present with issues related to disabilities and prenatal diagnosis, and Kelly had given me some common questions that parents in the disability community frequently asked. So before I get started, I wanted to let everybody know that the National Catholic Bioethics Center and our services include 24 hours a day consultation services. So we have information on our desk, and for everybody who's viewing, you can find the National Catholic Bioethics Center through their website by doing a search for the National Catholic Bioethics Center. We are 8 ethicists strong, and so there are always ethicists available to answer any of your questions, so please feel free to contact us, and we're always happy to help everyone. So I think that the conversation today can start with some of the more fundamental foundational questions that we have in our society. Our society, as Pope St. John Paul II has stated in the past, is focusing less on a culture of life and more on a culture of death. And so we're faced with complex medical questions and complex moral and bioethical decision-making questions that perhaps even 30 years ago when I became a nurse, we didn't have before us as often. So I worked for almost 10 years at Nemours, which is a children's hospital in Delaware. And so I have a near and dear appreciation for parents and special needs children. So when Kelly's email came across asking us to attend, I was very happy to be here. And I come with great awe and inspiration for all of you, with the commitment and the love and the care that you provide for your children, and in great trepidation because I'm not qualified to answer all of your questions. But in light of that, if we can start by, I'm going to read some of the questions that Kelly had sent to me via email, but before I read those questions and before I answer those questions, I would like to talk a little bit about the nature of the world that we live in that predisposes us to the complexities of some of these issues. So when I first became a nurse and I worked in labor and delivery, and we would deliver small, beautiful children, we didn't always have the pre-knowledge that a child would be born with a disability or a genetic abnormality. And so when these children were born in labor and delivery, and we were, as healthcare providers, were either resuscitating children or assessing them for their APGAR scores, we would determine something was wrong in the moment of birth. Today we have great strides in science that provide us with the opportunity that we can know if our children have a presusceptibility or a definitive healthcare anomaly. So the prenatal diagnosis conversation is where I think that we should start today. Prenatal diagnosis is really part of prenatal care today. And so a lot of mothers sign for consent for prenatal diagnostic testing without fully being aware of what that consent entails. With great knowledge comes great responsibility, and healthcare providers should provide parents with knowledge of the impact that some of the prenatal diagnoses could impact on families. And I'm not sure if everybody is aware, but with prenatal diagnostic testing, sometimes it's not absolute. And so the healthcare providers are presenting family with conversations that include linguistical terminology. Your baby has a lethality. Your baby is not compatible with life. We need to have a conversation. They have a presupposition to trisomy, well, now we can diagnose trisomy 13, 18, and 21, but then what does the parent do with that information? And many healthcare providers present the only option is to end the pregnancy. Years ago, they would say, we need to induce early abortion. We need to have early termination. Today, they're using language that doesn't come directly out and say your baby should be aborted. They have a genetic or chromosomal abnormality. They're telling people that the babies have a lethal condition, and your only treatment intervention is a surgical intervention, and they're not calling it an abortion, and they're not calling it a termination of pregnancy. And then there's pressure for people to respond immediately as opposed to going home and thinking about it. I heard a story in Charlotte a couple months ago when we were there talking about before and after birth complications, that a very Catholic, very pro-life woman who was given this bad news, who was told she needed a medical intervention because of the lethality of her baby, consented for the termination without knowing it was a termination. People are in emotional states, and so didn't even realize until she got the hospital bill and the surgical procedure was written as an abortion, did the horror appear to her knowledge that something horribly had gone wrong. So the first, the questions that Kelly gave me included conversations such as, if a family has multiple disabled children and multiple other children, say 7, is it ever acceptable to have a tubal ligation or to get their tubes tied? Overall family planning and how to open to how is being open to life for the couple, how does that impact us when we have a couple who's predisposed, who knows they have genetic disability within their own family? And these are real issues that all of the families who have children with disabilities face. Do I have a condition that's genetic? Do I have the predisposition? I think one of the other questions was, my daughter has a genetic disorder. Any children she will have in the future will have a 50-50 chance of also having the disorder. If she feels called to marriage, and if she and her future spouse discern that in order to not pass on the disorder, they would plan on using natural family planning to avoid pregnancy, their whole marriage, and adopt children instead, would that be considered a valid marriage? So the conversation for couples who know that they have a presusceptibility for children with disability, now parents they know the information before they go into a marriage that maybe they have the 50-50 chance of passing on these chromosomal and genetic disabilities to their future children. And people know that we have prenatal diagnostic testing to show us that a child who has already been conceived has a susceptibility to that diagnosis. So we are faced with this complexity of questions that we didn't have, say, 30 years ago. So what do we do with all of that information? We know it's laboriously related to increased expense for medical expenses, and so what does a couple do? And so this is a common question. Well, the answers are unfortunately multifaceted. Conversations need to be had with people who are trained in canon law, which I'm not trained in canon law. We at the National Catholic Bioethics Center take some of these questions by a case, well, all of these questions by a case-by-case circumstance. So unfortunately, we a lot of times say, well, it depends. We need more information. So to answer the question genuinely about a family that has multiple children and they're contemplating whether or not a tubal ligation would be acceptable in the Catholic Church, we spend a lot of time at the NCBC talking about the permissibility of the permanency related to hysterectomy, or like the hysterectomy was the most recent conversation. And then most of the time when people talk about not conceiving children, they're talking about having a surgical vasectomy where the male would have a direct sterilization. And church teaching is pretty clear on this. Direct sterilization is never permitted unless there's a pathology associated with something being physiologically or physically wrong with that reproductive organ, right? So I, as a woman, if I wanted to have a hysterectomy or tubal ligation because I didn't want to have any children or have any more children, with church teaching, which is extremely relevant and full of love and wisdom in its teaching for participants, would not be permissible, and neither would a vasectomy. So the encouragement then would be not to say, no, a tubal ligation's not permissible, you're still on your own with your natural family planning mechanisms. We should probably provide a lot of education, a lot of support with the natural family planning teaching for couples who are in this area of concern. Does that answer everybody's question in regard to it? Does anybody else have a question in the audience related to the permissibility of permanent or direct sterilization? Anything to add, Dr. Zelot? No. Okay. And we can always talk later as well. The marriage must be open. So when we talk about marriage and its consummation as a sacrament, marriage must be open to the generation and education of offspring. Now, that being said, people that have a genetic or chromosomal predisposition for children, they are permitted to adopt, right? So adoption is always permissible. And then use of natural family planning in trying to avoid having children is permissible. But then if a pregnancy occurred in the midst of the natural family pregnancy, then termination is never permissible. So with the prenatal diagnosis, we instruct people to really instruct families and couples to know what you're consenting for. If you're going to consent for prenatal diagnostic testing, what then are we going to do with the information if a baby supposedly has a pregenetic abnormality? So in our Catholic tradition, we would not choose to abort the child because of a poor prognosis. So in that regard, there's a lot of resources to provide supportive resources to carry to term. One of the organizations that's nationally known as Be Not Afraid, Philadelphia, the Archdiocese of Philadelphia, was trained by the Be Not Afraid program, and so in the Archdiocese of Philadelphia, we have a support service group called Lily's Gift, and that's another resource for couples if prenatal diagnosis is an issue. And a lot of couples can be educated to know that you don't have to consent for this prenatal diagnosis. You can opt out and not have the prenatal diagnosis and carry to term and wait and see what God provides for you. There's evidence and research that suggests that even baby with genetic and chromosomal abnormalities, with mothers who do not receive the prenatal diagnosis, the babies have better outcomes when they are born because the mothers do not know that the child has a perceived poor prognosis. And the research is indicating that women who do receive the poor prognosis because of stress responses and because of the increase in cortisol and the other physical anomalies that happen with women who know that the pregnancy is going to be a difficult pregnancy have decreased outcomes in the survivability of the baby long term. So I think a lot of that education needs to get out there to our parishioners and to couples in pre-Cana training to know that you don't have to have this testing because it might be easier if you have the support of your diocese and your family and your doctor without it. And then the other question that Kelly provided for me was, the doctor wants my 18-year-old daughter with Down syndrome to take the pill for problems related to her cycle. is that permissible? So the big response here is that it depends. We would need to know more information. What are the problems with the period? Does she have progesterone or estrogen related abnormalities? So in that regard, if there's a physical reason as to why the child would need to be on some type of contraception hormone for the response of maybe heavy bleeding or heavy pain or that kind of thing, then the conversation would be around that physiological or physical process and what is exactly the problem. A lot of doctors seek to prescribe contraception for anyone with special needs, the girls with special needs, because they're trying to contracept in case there was a sexual encounter that the child would not have a pregnancy, and so that would not be permissible. So we would need to know what is the rationale, what is the reason that the doctor is prescribing, and are there any questions related to that? Has anybody experienced problems with adolescent girls with, say, Down syndrome or autism, where pediatricians have recommended contraception as soon as they've menstruated?
Pediatricians so much, but what I've come across is a lot of times people will say, well, your daughter has can take contraception in order to minimize the negative, the pain or the like that they might be feeling around the period. And so therefore friends and others will often offer that, but I've never heard it from a pediatrician.
There's another question.
Not a question so much as a comment from a pediatrician did recommend, but it could have just been a general recommendation for the age for the Gardasil vaccination for my daughter. But I understand it's also for boys. It can be used for boys, but specifically for my daughter, which we refused. But that was just a comment.
So the Gardasil that is the vaccine for HPV viruses, and so the HPV virus they've found with research is significant, it increases the risk significantly for cervical cancer. And I just learned within the last week or so that there's been adjusted physician recommendations for pap smears and HPV testing to be used in replacement of pap smears because the HPV is what more greatly increases risk for cervical cancer. So we've had this conversation at other NCBC ethics seminars where even the discussion entailed, I have a normal adolescent who the state requires or the state recommends Gardasil HPV vaccinations. And as a parent, what is my moral obligation in providing that vaccine to even a potentially normal adolescent girl, let alone an adolescent girl with disabilities? And again, I think that the medical community is looking at it as this is going to be an entity that decreases cervical cancer risk in the future for anyone who is any females who are sexually active. So the conversation then surrounds our parental responsibility in, does this indicate by taking our children for this Gardasil vaccine that they're going to be sexually active and be potentially at risk for HPV? And so the recommendation from the NCBC is that we wouldn't promote the Gardasil vaccine because, and we've had conversations back and forth, well, what happens if the husband someday that the girl is marrying was sexually active before he decided to marry, and say then he would infect the girl with the HPV virus? Should we just protect our daughter regardless? And so that moral conversation of, say, cooperation or misinforming our children and thinking that, well, you've had this vaccine, it'll protect you from getting something that can only be transmitted sexually is problematic, right? So you chose not to have your daughter vaccinated, which would probably correlate to choosing to not have your daughter on contraception, unless it was for a physical reason. It's interesting that the conversation that you brought up would include, well, the contraception would help eliminate any abnormal discomfort related to periods or the premenstrual syndrome, without even knowing if the premenstrual syndrome actually was occurring.
Maybe just a little more clarity, or maybe lack thereof, on some of the issues that have been raised. Related to the question of prescribing hormonal medications, which could act as contraceptives for females, one of the things that, and I'm not a medical doctor, but we talk to a lot of them, and one of the critiques of just essentially the handing out of hormonal medications, hormonal contraceptives today, for whether it's discomfort or heavy bleeding or whatever, is that these medications, they mask the symptoms, but they don't get at the underlying issue. And so the response that we will give is, as DiAnn was saying, the most important thing is, okay, let's look, what's the underlying medical condition, and let's deal with that first. I mean, it could possibly be a situation where there is a hormonal imbalance, and thus a hormonal regimen may be the correct way to do it. But the first thing to do is say, to the best of our ability, let's try to figure out what the underlying condition is. In relation to physicians or others who prescribe contraception, particularly for, I shouldn't say prescribe contraception, I should say provide hormonal treatments that act as contraceptives, for developmentally disabled women. I actually get this phone call, I don't want to say fairly often, but it comes up a few times a year. We'll get a call from a diocese or a Catholic Social Services office of a diocese, not from Camden, don't worry. But the question is, we have young women who are in group homes or are in communities that aren't safe. And the argument is, whether it's coming from the pediatrician or coming from another person, is that we want to put these women on birth control pills to protect them. And is that okay to do? And there's a logic to that. And our response is, well, it's not. And we talk about, well, if the person really is in danger, putting them on pills, that's not going to take away the danger. I mean, what we should be doing is focusing on the danger. And also that, if there are men in the, other people in the group home or other people in the community who know that this developmentally disabled female is on birth control pills, well, she's free game. And so by doing that, you may actually expose her to more danger. But we do get this question about, it's a self-defense question. Is this what we should be doing to protect these young women from essentially sexual predators?
Thank you, Dr. Zelot.
Would like to comment on the same topic. My sister was the only girl or young woman at the residential school that she attended who was not on contraception. I think the biggest reason was because it was easier for the staff if they knew exactly when every girl's period was going to occur, how long it was going to last. It just made their lives easier. And she was sexually assaulted by another resident while she was there. And again, allowing a sexual predator to live in her house was really the problem, not contraception would not have kept her safe from that.
And I think that that's the sad reality, and that's the sad decision-making that everyone with a female child with a disability has if they're in a residential center, or even if they're in a residential daycare setting where you're picking them up every day. The agonizing experience is just something unimaginable. I think Father has a question.
Well, I just had a follow-up here, because the self-defense thing, if we look at, there is basically using some form of douche after an attack is morally permissible if it was a non-consensual or coerced in any way sexual encounter where a male coerced a female. You can use, like, I believe at least, you can use like a douche to attempt to prevent to clear out whatever kind of sperm are inside the uterus at the moment, I believe is acceptable.
And so there's protocols.
As one thing in cases like this, as if something really bad happens.
And the sad reality is that with a nonverbal female with a disability, are we receiving the notification that an assault happened? Just like that sad case, it was in Texas where the young lady, nobody knew that an assault had happened until she was pregnant. And she had been cared for many months before the pregnancy was found. And so being a nurse that had cared for many people with disabilities, a lot of times, even if they are verbal, how does a young girl express that type of assault, especially if there's a cognitive delay in knowing what really just happened to them? So unless someone witnesses the assault, in many, many, many instances, it could be repeated over and over and over again without people really knowing.
Oh, no, definitely. I just wanted to mention that.
Right.
It's kind of related.
No, it's definitely, and there's that's a whole nother conversation. So this is like very emotional that people could be so violated. If there isn't anything else to add to that topic, there was one additional topic that Kelly had posed before us, and it was about parents expressing concerns because of for end-of-life issues. So the question says, parents also express concerns about providing treatment versus palliative care, and how to find out if the treatment being offered to their child is ethical versus, and then there was also some fetal stem cell questions, but I think they're almost two different questions. So I want to answer the question about providing treatment versus palliative care, and how do you find out if that treatment is ethical. So again, that question depends upon circumstances. So sometimes, and I think Mary did a beautiful job when we started out the day speaking about how the end-of-life decision-making and her advocacy for her daughter included insurance that over-sedation and pain medications that could stop respirations weren't utilized, how providing normal care interventions such as feeding occurred. And we're living in an age where the aid in dying legislation was passed in New Jersey on April 12th, and I'll remember that forever. It's my son's 25th birthday on April 12th. The governor signed, I believe, on April 12th. It had passed legislation before that. And a lot of our concerns in the medical community are for the nonverbal, for those with cognitive disorders, for those with disabilities and those with disabilities at end of life with cognition and changes in levels of consciousness. And I just returned from a nursing ethics conference at UCLA where there was a robust conversation regarding spoon feeding of someone with Alzheimer's disease is a medical intervention, and so if the person doesn't want care, then spoon feeding can be ordered to be discontinued. And 2 people in the room of like 45 in a small conversation said, yeah, that's acceptable. Like if somebody's at end of life and they're on hospice, and even if they can eat and even if they enjoy their ice cream, if they don't want to live in a state of constant dementia, then it would be okay to stop spoon feeding grandmom. We want the medical facility to stop spoon feeding grandmom. And 40 of the nurses said that's not acceptable, that's normal care. Feeding someone who can't feed themselves with a spoon or fork is normal care. It's not extraordinary care. It's not an artificial tube in their stomach that's feeding them at end of life. So how do we navigate through this language that's definitely starting to change? How do we care for our children with disabilities as they grow into adults with neurocognitive disabilities, and who are the people that are going to care for them long term? And so there's wonderful teaching, Catholic teaching, in relationship to what is extraordinary, considered extraordinary care, and what is ordinary care. So to answer the question about providing palliative care at end of life for comfort versus, putting someone on a ventilator and giving them artificial feeding that's not normal at end of life is a whole big conversation. So if children are actively dying, to provide palliative care, comfort care, and hospice care that doesn't seek to expedite the death, then that would be morally permissible. And when people are actively dying, they naturally, physically stop eating. Bowel sounds go away, need to eat go away. And so at end of life, when someone's in that last 8 hours of life, you might try to give somebody some broth, try to give somebody a bite, and they'll turn their head and maybe they throw it up or they can't tolerate it. That's way different than stopping feeding someone 2 weeks before that end of life time period. So consciousness with pain medication is important. We don't make someone completely go to sleep and not have any respirations. Those type of things are not permissible. So as parents, as Mary advocated for her daughter, we would ensure that the healthcare providers did not do anything that expedited the death of the child. Any other questions related to that? Any other experiences related to encouragement of healthcare providers to place a child on a no intervention palliation when you felt as the parent that was not taking care of the physiological needs that your child had, who was not actively dying? Nobody has had experience with that in the room. Thank God, right? All right.
Thank you very much.